Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now let's get started. Today we're going to dive into the scientific publication with the title, Diagnostic Lymphangiography with Therapeutic Effect. Since more than 70 years, Lipiodol is used as an off-label standard of care for chylothorax. Why not convert to on-label use? By Frank Mosler, Nando Merteniet, Manuel Kampmann, and Gerd Nolch. Background: Lipiodol is a clear, oily liquid, a mixture of long-chain C16 and C18 diiodinated ethyl esters of fatty acids of poppy seed oil. The content of predominantly fatty acids amounts to 79%, of which 98% are unsaturated. It contains iodine at a concentration of 480 mg per milliliter. The viscosity at 37 degrees Celsius is about 25 Pascal seconds, and its density is 1.28 grams per cubic centimeter. It was first synthesized by the French pharmacist Marcel Guerbet in 1901 and was presented by his colleague Laurent Lafay in the same year as the world's first iodinated poppy seed oil. In 1921, the French radiologists Jean-Athanas Sicard and Jacques Forestier discovered the X-ray attenuating property of Lipiodol. Subsequently, this led to its first use as an X-ray contrast agent in the investigation of a spinal cord tumor by means of myelography, without any side effects occurring. Other radiological applications followed in fast sequence: bronchography in 1922, dacryography in 1923, hysterosalpingography in 1924, and scilography, fistulography, ureterography, and cystography in 1920. The hysterosalpingography, in other words, contrast filling of the uterus and the fallopian tubes for ruling out occlusion as an infertility cause, is a very interesting use case, and today every bit as important as it was a century ago. In 1937, Lipiodol ultrafluid was even used to visualize the intrahepatic and extrahepatic bile ducts as part of a percutaneous transhepatic cholecystography and cholangiography. Lipiodol ultrafluid was also used therapeutically in the treatment of goiter in the third decade of the last century, as reported by Wolf in his 2001 publication. Lymphography. In 1952, Lipiodol lymphography was first performed by Kinman and described as a clinically relevant method. In the 1960s, lymphangiography was of great importance for the anatomically precise visualization of the lymphatic system. In other words, the lymph nodes and lymphatic vessels, and detection of tumors, which nowadays is an emerging domain of magnetic resonance lymphangiography. In the classical approach, lymphangiography is performed via a lymphatic vessel stained by patent blue at the dorsum of the foot unilaterally or bilaterally, while the more modern approach is an inguinal intranodal US-guided lymph node puncture, which is much less invasive. After gaining access to a lymph vessel, slow Lipiodol ultrafluid injection is monitored under fluoroscopy with contrast volumes ranging from 10 to 20 milliliters in total. Contraindications of IV Lipiodol ultrafluid are summarized in Table 2. Before cross-sectional imaging became widely available in clinical practice, lymphangiography, due to its anatomic depiction quality, was the mainstay diagnostic tool in the workup of lymphatic diseases, such as lymphogranulomatosis, Hodgkin's disease, and sarcoidosis. Lipiodol lymphography also rendered possible a valid examination answering the question of metastatic spread in the lymph vessel system, based on marginal and central Lipiodol storage defects in the lymph nodes. Main part: lymphography or lymphangiography as a diagnostic method was first performed by Kinman in 1952 and described as a clinical method. With the beginning of the 1960s, it became increasingly important as a diagnostic tool for imaging the lymphatic vasculature with contrast enhancement of lymphatic vessels and lymph nodes. After introduction of cross-sectional imaging, lymphangiography experienced even an increase in its diagnostic value. Together with cross-sectional imaging, it is widely used in the detection and therapy of lymphatic leakage. In a 2018 review, Kim and others reported a technical success rate of lymphography and thoracic duct embolization of 92.2% from their analysis of 9 studies with a total of 407 patients. The pooled clinical success rate of lymphography, thoracic duct disruption, and thoracic duct embolization on a pre-protocol basis were 56.6%, 79.4%, and 60.8%, respectively. Today, when it comes to pathological changes, such as metastatic involvement of lymph nodes or detection of metastases, the various modalities of cross-sectional imaging as a diagnostic tool, both non-invasive or semi-invasive, have undoubtedly become the methods of first choice. They have largely replaced Lipiodol ultrafluid lymphangiography as a first-step diagnostic tool in screening examinations in lymph nodes. However, Lipiodol lymphangiogram defends its role as a highly sensitive and highly accurate method for detecting lymphatic leakages. Hence, the role of Lipiodol lymphangiogram should focus on lymphatic leakage cases and be performed in combination with cross-sectional imaging or without. The importance of Lipiodol ultrafluid as a diagnostic agent is underlined by the high number of publications listed on PubMed for the years 1921 to 2021. Despite being a clinically tried and tested therapeutic agent, in Switzerland, Lipiodol can only be utilized off-label for the treatment of lymphatic leaks. The selection from the present literature further emphasizes its value as the most accurate method alone, and in combination with cross-sectional imaging in the accurate detection of lymphatic leakage with fluoroscopy, CT, and MRI. Pediatric populations. Lymphangiography is used not only in adults, but also in the diagnostic workup of children for the detection of lymphatic leaks, with subsequent thoracic duct embolization or thoracic duct disruption. These are mainly individual cases or small case series with a maximum of 11 children. A search of the PubMed database with the keywords Chylothorax lymphangiography Lipiodol children yields, as compared to the large number of publications in adults, only a negligible number of publications in pediatric patients. Of note, Lipiodol-based investigations or interventions are technically more demanding in children as compared to adults, due in part to lack of cooperation or the need of general anesthesia. Chylothorax. In adults, the basis for a minimally invasive therapy for chylothorax rests on chest drainage drawing fluid macroscopically consistent with chyle. Laboratory confirmation of chyle composition and lymphangiography confirmed lymphatic leakage. The natural history of an untreated chylothorax leads, via malnutrition, to increased morbidity and mortality risk. The volume of chyle fluid leakage into the interpleural space can exceed 1.5 liter per day. Treatment often is performed by percutaneous, minimally invasive embolization of the thoracic duct via puncture of the cisterna chyli and insertion of a microcatheter. Transcatheter embolization of the thoracic duct is performed with a tissue adhesive injection, for example histoacryl alone, or more often in combination with embolization coils. The intervention is monitored with fluoroscopy and finally controlled with cross-sectional imaging. Above procedure is considered much less invasive than open surgical or endoscopic thoracic duct ligation, with comparable closure success rates. Percutaneous minimally invasive thoracic duct closure in 89%, open surgical closure by ligation in 95%, thoracoscopically, or in a newer retroperitoneoscopic approach by ligation with closure in 75%, with significant reduction of chyle leakage. Lipiodol ultrafluid is chosen for intention to treat use as a minimally invasive therapeutic method in chylothorax or general treatment of lymph leakage only in off-label use in these patients in combination with glue or coil embolization or needle disruption. However, it may also be repeatedly administered in off-label use. if final closure of the lymph leakage has not occurred after first application. Single or even repeated Lipiodol lymphangiography has been described as an effective therapy for chylothorax. Regulations. Off-label use is permitted in individual cases as a curative attempt to close a chyle leak under certain conditions, and each case can be medico-legally challenged. The responsibility lies with the treating physician, who must provide detailed information for each case. Profound medical reasons for off-label use in that specific case and indication must be provided to the patient prior to the procedure. This means that all pertinent pros and cons must be discussed, and all the patient's questions must be answered. Alternative therapeutic options must be explained to the patient. Informing the patient about the off-label use of Lipiodol ultrafluid is of utmost importance and must also be documented. The process of dialogue, explanations, and gaining informed consent is time-consuming for physician and patient. If the physician fails to get an informed patient consent, including the off-label usage, he might be held liable. Many malpractice suits hinge on the fact of missing and/or insufficient patient consent documentation. The authors have noticed that in the majority of publications reviewed, there is no express mention of how and whether the off-label use was explained to the patient, or whether consent for this off-label use was obtained and documented, with one notable exception. However, if one implies a high standard of good clinical practice and knowledge of the medico-legal situation of the respective authors, it should be assumed that a comprehensive information and written consent of the patients were presumably carried out, but just not mentioned. However, from a psychological point of view, having to explain to the patient that an off-label drug employment is the best therapeutic option might put a strain on the trustworthy relation between patient and physician. For example, the patient cannot get the same reassurance from a physician's statement that a drug is off-label as she or he would get if it were on-label. Hence, even if the physician is experienced in the therapeutic use of Lipiodol ultrafluid, he cannot fully convey this to the patient. If Lipiodol ultrafluid is de facto used as first-line therapeutic option for chylothorax in the described variations since 1951, why does it still not have an according approval 70 years later? For the interventional radiologist, there are two other minimally invasive options for occlusive therapy of chylothorax. When the primary attempt to treat the lymphangiographically precisely localized point of origin of the chylothorax by conventional dietary medical measures fails. Targeted percutaneous CT-guided alcohol ablation of a lymphatic leak, previously detected with Lipiodol ultrafluid. Minimally invasive percutaneous needle dissection of the lymphatic leakage site. In addition to the primary diagnostic indication, and according to its package insert, Lipiodol ultrafluid has the second and unrestricted approval to date for therapy of a hepatocellular carcinoma of the liver. Lipiodol ultrafluid for this purpose is injected as contrast agent in order to localize and mark the tumor in the liver, and secondly, as a carrier for the chemotherapeutic agent, which is then injected superselectively into the nutritive vessels of the tumor via microcatheter. Lipiodol ultrafluid has a vaso-occlusive effect, which contributes to an additional improvement of chemoembolization in the treatment of the tumor, whose arterial blood supply should be eliminated totally, if possible, by capillary embolization inducing complete tumor necrosis. Trivial as it may be, every potent drug tends to have its contraindications. For Lipiodol ultrafluid, these are summarized in Table 2. As far as the efficiency of Lipiodol ultrafluid as a single theranostic agent is concerned, this would mean that the use of Lipiodol ultrafluid as a medication in an emergency, such as a therapy-resistant postoperative chylothorax, would be the liability of the interventional radiologist performing the procedure, without creating the legal uncertainty of an off-label use. The main alternative, avoiding these medico-legal liabilities, is the established surgical therapy, with repetition of general anesthesia and surgery, running an increased risk of morbidity and mortality, especially in aged patients or in those with significant comorbidities. Therefore, from an ethical and medico-legal standpoint, and for the creation of a trusting doctor-patient relationship, it would be in the patient's best interest for Lipiodol ultrafluid to be approved as a lymph leakage closing drug as soon as possible. The answer to the question posed at the beginning, in which countries there is a license for Lipiodol ultrafluid as a therapeutic agent for chyle leakage, can be answered swiftly. There is worldwide no such license or approval for Lipiodol ultrafluid as therapeutic agent for chyle leakage. In the package insert for Lipiodol ultrafluid from Guerbet Company, Villepinte, France, which is valid for Switzerland, only 2 indications are listed. 1. Lymphangiography with Lipiodol ultrafluid for the visualization of the lymphatic vascular system, and thus for the detection of lymphatic fistulas, lymphatic leaks, chylothorax occurring postoperatively as a result of trauma or spontaneously, and finally cholascos. 2. Superselective angiography with Lipiodol ultrafluid in the context of transarterial chemoembolization to mark and treat a hepatocellular carcinoma. Conclusions. 1. The existing clinical radiological experience of decades using Lipiodol ultrafluid as a safe therapeutic agent for the closure of lymphatic leaks should make it possible to convert the existing off-label use of Lipiodol ultrafluid into a regular approval for an intention to treat use in a chylothorax, a cholascos, a lymph fistula, or lymph vessel leakage. 2. If this is not possible according to the regulations of the responsible authorities, despite of the already existing data on the efficiency of Lipiodol ultrafluid in the treatment of a lymph vessel leakage, then a retrospective study and or B, a prospective single-center study and or, if necessary, C, a multi-center study are the possibilities to convert the existing off-label use into a regular intention to treat on-label use, with quite some urgency after 120 years of clinical usage and good experiences. 3. In our opinion, it is mandatory for the manufacturer of Lipiodol ultrafluid to protect physicians from potential legal issues when using Lipiodol ultrafluid with intention to treat on patients by an official FDA admittance for on-label use with intention to treat of their product. This special FDA admittance procedure is of course long-lasting and very expensive for the manufacturer. 4. Obviously, financial reasons should not interfere with legalization of very long-known and commonly accepted standard of care procedures. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.